Hello, my name is Garrick Stewart. I'm a physician in the Center for Advanced Heart Disease at Brigham and Women's Hospital, and today we'll be talking with you about mechanical circulatory support. I have no relevant disclosures. Let's begin with an overview of the next 45 minutes to an hour of these remarks on circulatory support. I'll talk with you about the evolution of durable ventricular assist devices to the current generation magnetically levitated pumps. We'll talk about different pump support strategies, device configurations, and then patient profiles of those who may benefit the most from these devices. We'll talk a little about selecting candidates for device therapy, as well as the complications stemming from mechanical circulatory support. And then we'll finish on temporary circulatory support devices that are now in widespread use. The heart failure disease course tends to be one of inexorable decline. There is an initial insult to myocardial functioning, whereby physical and contractile function is diminished, that then is rescued with medical and device therapies over a period of time. The disease course can be punctuated by episodes of sudden death, and then decompensations of heart failure that over time lead to reduced functioning and quality of life. In very select patients, those with stage D or class 4 heart failure, they can sometimes get a durable support device or a heart transplantation that can reset them to an earlier phase of the disease course. Even though transplant is the gold standard for cardiac replacement, cardiac transplantation is not enough to meet the advanced heart failure epidemic. These are transplant data from the International Society of Heart-Lung Transplant that demonstrate in yellow for Europe and green for North America that the number of heart transplants has been relatively stable over the last 20 years. Despite this, the 2,500 donor hearts implanted in the United States every year are just a small slice of the roughly 180,000 patients suffering from advanced systolic heart failure. Because of this mismatch in the epidemic and the available donor organs, mechanical circulatory support devices have been developed to meet the needs of our patients. And the story of these support devices is really one of a triumph of engineering. Over the last 15 years, we've gone from very large implantable pulsatile pumps, here on the left, the HeartMate XVE, to the pump that really revolutionized circulatory support, the HeartMate 2 axial continuous flow pump, to more contemporary centrifugal flow pumps, which are much smaller and available for intrapericardial implantation. These durable mechanical circulatory support devices come in a number of different configurations. In most widespread use are left ventricular assist devices. These are support devices that connect to the apex of the left ventricle, have a rotor that accelerates blood flow through an outflow cannula into the ascending aorta, thereby pressurizing the arterial circulation and unloading the failing heart. If both ventricles are failing, there are two options: both biventricular assist devices, where there can be a right and left-sided assist device placed, as well as the total artificial heart, whereby the ventricles are removed and replaced by parallel cardiac pumping chambers. These support devices, in turn, are deployed in a number of different strategies. The first to be approved and still in widespread use are using a device as a bridge to cardiac transplantation. This allows us to support the blood flow, circulation, and enhance the quality of life of those patients who are on the transplant waiting list and need to make it until a donor heart becomes available. In addition, pumps can be used as so-called destination therapy for lifelong support in those patients who may be ineligible for transplantation by virtue of age or other comorbid medical conditions. And naturally, there is some overlap in patients who are listed for transplant and might become listed one day Those are sometimes referred to as bridge to candidacy patients, patients where a support device may improve kidney function or reduce pulmonary hypertension such that they're rendered eligible for transplantation. In addition, devices can be used as a bridge to recovery for more acute cardiac insults like myocarditis or peripartum cardiomyopathy. And the reason to emphasize these different support strategies is that as a bridge to transplantation, all the different pump configurations are available: LVADs, BiVADs, and the total artificial heart. But at present, LVADs alone are the only approved circulatory support devices for those not listed or not anticipated to be listed for cardiac transplantation. And so the strategy defines the Food and Drug Administration device indication. With that, let's move to the landmark clinical trials in circulatory support. And our story begins with the REMATCH trial, published in 2001. And this was the sickest population of heart failure patients ever randomized to a device versus medical therapy. These patients were all not transplant candidates. They all had an ejection fraction less than 25%, and severe heart failure as represented by a peak VO2 less than 12 or the dependence on an infusion of inotropes. This, on the right, is a cartoon of the pulsatile subdiaphragmatic HeartMate XVE. This was an electrically driven pusher plate pump that was loud, fairly bulky, but even so, these were the results. In this first generation circulatory support pump, here represented in yellow, in these very advanced heart failure patients, there was twice the survival at 1 year with an LVAD compared to optimal medical therapy. This is truly remarkable in this day and age that any type of therapy can double survival. However, by 2 years, nearly 3/4 of patients had died despite receiving an LVAD, and nearly all of the patients on medical therapy had succumbed. This was an important trial because it led to the FDA approval for the HeartMate as destination therapy, the first such approved device. But the durability of these bulky pulsatile pumps slowed the adoption of this technology. And so the engineers continued to innovate by developing the continuous axial flow LVAD known as the HeartMate 2. Rather than having an electrically driven pusher plate, here was a rotor that was turning between 9,000 and 10,000 revolutions per minute. This was a valveless pump that ensured unidirectional flow with this electrically driven rotor. Blood gets sucked out of the apex of the left heart, accelerated through the housing of the pump and through the outflow cannula to the aorta. A driveline exits the skin, which is connected to a controller worn around the belt or the midline, which in turn is connected to external battery supply or a wall-mounted power unit. This is a cross-section of the pump inside where blood is accelerated through the inflow cannula, through flow stators and a rotor, and then out to the aorta. The older pulsatile pumps were then compared head-to-head with the newer continuous flow LVADs in a destination therapy population. In this trial, published in 2009 in the New England Journal, the primary endpoint was survival at 24 months, free from a disabling stroke or reoperation for device replacement. And there was a resounding benefit in favor of the continuous flow pump, with a hazard ratio of 0.38 with the continuous flow pump compared to the pulsatile pump. If we look at the individual components of that primary endpoint, the endpoint was driven largely by a dramatic reduction in the need to reoperate to replace the device, but also a reduction in death at 2 years with the continuous flow compared to the older pulsatile pumps. There was no significant difference in the rate of disabling stroke. And so here we have, in a single curve, the first decade of the 21st century in mechanical circulatory support. In advanced heart failure, medical therapy has fairly poor results, even in patients who are eligible for VADs. And if they do get a support pump, there's a doubling of survival with a pulsatile pump and a further increase in survival with more contemporary continuous flow pumps, such that survival today at 1 year is in excess of 80%, even better than that seen in the clinical trials. There's been further innovation and miniaturization of pumps, including that of the Heartware HVAD, a miniaturized pump that allows an intrapericardial implant because the pump itself is scarcely bigger than a golf ball. This can give up to 10 liters per minute of flow and has a centrifugal design allowing continuous flow with a rotor spinning side to side and blood leaving at a 90-degree angle from where it enters the pump. There's a thin, flexible driveline that allows greater patient comfort. This is a cartoon comparing the centrifugal flow pump to the axial flow pump, in this case the Heartware HVAD, compared to the HeartMate 2 LVAD. The blood paths are different, but both provide continuous flow in a valveless pump with silent stealth running that allows greater patient comfort and less obtrusion to neighbors and colleagues. The current generation of pumps doesn't just have centrifugal flow, but actually has a fully magnetically levitated rotor that allows wider blood flow paths through the pump, less shearing, and improved hemocompatibility between the blood and the pump surface. This is the HeartMate 3, recently studied in the Momentum clinical trial, where 2-year outcomes were published in early 2008 in the New England Journal. Again, with a primary outcome of survival free of disabling stroke or reoperation to replace or remove the pump, compared to the HeartMate 2 axial flow pump, there was an even further improvement in event-free survival with the centrifugal flow, fully magnetically levitated HeartMate 3 pump, with a primary endpoint that was significantly better with the centrifugal flow pump compared to the axial flow pump. And this endpoint was primarily driven by much greater freedom from reoperation to replace or remove the next generation HeartMate 3 pump. So to review these two different pump profiles, the axial flow pumps, blood moves in and out of the pump in a straight line. An example is the HeartMate 2, whereas the centrifugal flow pump, blood moves in and out of the pump at a 90-degree angle. And these current pumps are the HeartMate 3 and the HVAD, which represent the most widespread devices in current use. The axial flow pumps and the earlier pulsatile pumps I was showing you are subdiaphragmatic implants, whereas the centrifugal pumps are small enough that they can be intrapericardial implants. Axial flow pumps are much more preload sensitive, whereas centrifugal flow pumps are much more afterload sensitive. Blood pressure control is critical for optimal use of centrifugal flow pumps. We tend to target a mean arterial pressure less than 90 millimeters of mercury for all continuous flow devices, as well as an INR between 2 and 3. And the HVAD, by virtue of its small size, has even been used in a fairly widespread fashion for biventricular circulatory support, an HVAD on the left as well as the right. But of course, it's not just survival that's improved with LVAD therapy or left ventricular assist device therapy, but also quality of life. These are data from the HeartMate 2 series of trials looking at disease-specific quality of life, in this case, heart failure-related quality of life from the Minnesota Living with Heart Failure questionnaire, where higher scores represent a more severe burden of heart failure. Pre-implant, there was a lot of heart failure, and then even by 1, 3, and 6 months, a dramatic 30-point reduction in this quality of life metric, where a 5-point change is considered meaningful. In addition to quality of life, functional status is dramatically improved with LVAD therapy. These are New York Heart Class at 1, 3, and 6 months, and 82% of patients in the HeartMate 2 trials were in class 1 or 2 by 6 months. And this is in contrast to 98% of those patients being in class 4 or symptoms at rest at the time of implant. Objective functional capacity is also improved. These are comparative improvements in 6-minute walk distance in different therapies in class 4 heart failure. Carvedilol, a beta blocker, will get you about 19 more meters in a 6-minute walk. Cardiac resynchronization therapy, 46 meters. And then LVADs, either the HeartMate 2 or the HVAD in different clinical trials, giving you more than 100 meters of improvement in 6-minute walk distance in class 4 heart failure. Truly, a dramatic improvement in survival, functional capacity, and quality of life for the most advanced heart failure patients. Because of these outcomes, there's been widespread adoption of LVAD implantation over the last decade. The rates of approved device implants have been mapped by the Interagency Registry for Mechanically Assisted Circulatory Support, or INTERMACS. These are data from INTERMACS over the last decade. On the left, stratified by different implant strategies. In blue, bridge to transplant, orange, bridge to transplant candidacy, and gray, destination therapy. You can see there's been an uptick in the implant across all strategies, particularly destination therapy. The slight reduction you see in 2015 and 2016 is because of many of those patients were implanted with the HeartMate 3 in a clinical trial and so not registered in the FDA device registry. The panel on the right demonstrates that the vast majority of circulatory pumps that are implanted are left ventricular assist devices alone, here represented in light blue, followed by biventricular support devices and the total artificial heart. LVADs are the workhorse circulatory support device for systolic heart failure. Now, how do we select the best patients to receive durable mechanical circulatory support? Well, it begins with identifying those patients with advanced heart failure. There are several different ways that we describe advanced heart failure. In most widespread use are the New York Heart Association classes that you're quite familiar with. These range from class 1, functional limitation, which is essentially no symptoms, to class 4, symptoms at rest, class 3, symptoms with only light activities, and class 2 with moderately heavy activities. New York Heart Association classes can be quite labile depending on volume, status, and medical therapy. And so the American Heart Association and American College of Cardiology developed stages of congestive heart failure to emphasize that antecedent risk factors in stage A can lead to structural heart disease, or stage B. And then when there are both symptoms and structural heart disease present, that's stage C heart failure. The advanced heart failure patients are those considered to have stage D, or refractory heart failure. Those patients are often thought of as having symptoms at rest. But not all class 4 patients are the same. The Interagency Registry of Circulatory Support, or INTERMACS, has given us different profiles for describing the most advanced stages of heart failure. In contrast to the New York Heart Association class, the INTERMACS profiles have a lower profile with sicker patients, and higher profile patients are less sick. And these are the INTERMACS profiles. The sickest patients are in profile 1, or critical cardiogenic shock despite escalating support. Profile 2 patients are having progressive decline despite inotropic therapy with evidence of end organ dysfunction or evolving shock. Profile 3 patients are clinically stable but require a continuous infusion of inotropes. Profile 4 patients have class 4 heart failure but recurrent advanced heart failure decompensations. Profile 5 are exertion intolerant. And profile 6 patients are really New York Heart Association class 3B, who are limited, can do mild activities, but get fatigued within only a few minutes. And then profile 7 is a holding profile for advanced class 3 patients. So the lower the INTERMACS profile, the sicker the patient. And it's the sickest patients who've been receiving LVAD therapy. In the latest version of INTERMACS, the annual report suggested that 87% of LVADs are placed in patients living in profiles 1 through 3, those in cardiogenic shock, progressive decline despite inotropes, or who are inotrope dependent. What are the specific triggers for referring a patient for mechanical circulatory support or left ventricular assist device? Well, first, the heart failure must be limiting daily activities. This is typically represented as class 3 or 4 heart failure on most days. These patients should have every effort to have optimal pharmacologic, resynchronization, and defibrillator therapy according to major society guidelines. And then if that's been attempted, we then want to ask ourselves, does this patient have a high risk for 1-year mortality? And that's a mortality risk greater than 15 or 20% in the next year from their heart failure. Some of the markers of risk include recurrent heart failure hospitalizations despite best efforts, persistent hyponatremia, typically a sodium less than 135, which represents neurohormonal activation, patients who have renocirculatory limits to the initiation of ACE inhibitors, angiotensin blockers, or beta blockers, those patients with a high or increasing diuretic requirement. Diuretic resistance is a potent marker of heart failure risk. You can use calculated survival scores, such as the Seattle Heart Failure Model, to estimate 1-year survival. Or we get cardiopulmonary exercise testing, and if there's a reduced peak VO2, less than 12 to 14, you can consider LVAD referral. Or if a patient frequently needs inotropes or is dependent on inotropes, or by the same token has recurrent or refractory ventricular arrhythmias, all of those clinical features are markers of increased mortality at a year. And all such patients should be considered for referral to an advanced heart disease center. Once they're referred, there are a whole series of considerations when selecting candidates for durable circulatory support. First, there are cardiac considerations, including the burden of arrhythmias and the need for inotropes, or concurrent valvular heart disease that may be able to be fixed and thereby prevent LVAD therapy, or might need to be fixed at the time of mechanical circulatory support. Right heart function is critical to assess to determine if a patient can get by with a left ventricular assist device alone, or if an RVAD will be needed too. And now these devices require constant patient-pump interaction. And so it's important to see that the patient is psychologically sound and has a good support. In addition, patients should not be of advanced age or have a competing risk of mortality from another clinical disorder like a malignancy or advanced chronic kidney disease. Patients should be nutritionally optimized and free of infection before considering implantation of such a device. And it's critical to focus on the right heart because those patients who are able to receive an LVAD alone tend to have much better outcomes than those who require biventricular support. Again, these are data of over 12,000 mechanical heart pumps from Intermax, and you can see by 1 and 2 years that survival with a left ventricular assist device, no matter axial or centrifugal flow, is dramatically better than a biventricular assist device. And most of that risk for BiVAD recipients is up front, probably because of the attendant and organ dysfunction that comes with having debilitating right heart failure, particularly renal and hepatic dysfunction. As we're selecting candidates, we often want to look at pre-implant clinical features that may give insight into the risk early and late after implantation of an LVAD or BiVAD. These data from Intermax demonstrate those pre-implant features associated with an early risk of death, that is death within 3 months of implant, really perioperative risk, and then those who have a late hazard of death. As you might expect, those patients who are older have both an early and late risk of death. Peri-implant risk is increased in patients who are a little bit larger, in female patients compared to men, and patients who are dependent on a ventilator, or who have the most advanced circulatory failure as described by Intermax profiles 1 or 2. Destination therapy patients do worse than bridge to transplant patients, and those with renal and hepatic dysfunction are at increased risk of early and, importantly, late mortality. Both advanced aged and chronic kidney disease are the most potent markers for reduced survival late after LVAD implantation. And then, as mentioned, other markers of right heart function, the need for an RVAD or a high right atrial pressure, are also signs of an increased hazard after LVAD implantation. And so how do I think of implanting patients with circulatory support? This is the algorithm that we tend to use when we shepherd patients through the decision to receive a circulatory support pump. We first want to make sure a patient is sick enough to justify the risk of the operation, the expense, and the potential complications of these devices. Heart failure should limit daily life, despite optimal pharmacologic and electrical device therapy. The next question we like to ask is whether or not a patient is eligible for transplant. If they are a transplant candidate and can be listed, we then turn our attention to right heart failure. If they're low risk for right heart failure, we then proceed with an LVAD as a bridge to transplant. And if they're very high risk and able to get a biventricular or total artificial heart as a bridge, we go down that path. Decision making can become somewhat more complicated in those who are ineligible for transplant. If patients are at very high risk for right heart failure after LVAD, those are the patients with the highest mortality. Remember that there's no biventricular or total artificial heart approved for those patients not contemplated as being a transplant candidate. And so palliative inotropes and attention to supportive cardiology and end-of-life care may be warranted. However, for ineligible patients at low risk for right heart failure, we then think about, are they at high risk for surgery itself? So older patients with multiple comorbidities, multiple reoperations who are at very high implant risk, it's critical to have shared decision-making whether it's wise to proceed with an LVAD or to go down a palliative route. But if there's an acceptable implant risk, then a destination therapy or lifelong LVAD can be considered, provided that the patient has robust psychosocial supports and a good family or friend network to help them early and late after implant. This algorithm illustrates the dimensions of decision-making when it comes to ventricular assist devices. We've talked about the survival benefits of these devices relative to optimal medical therapy, the potential benefit on quality of life when it comes to reducing heart failure-related quality of life deficits. But there's also a decrement in quality of life with the dependence on a machine and the interaction with that machine and the potential social impact of living with a heart pump, making you feel different from your friends and neighbors. In addition, there are the direct and indirect costs of these pumps, the lost opportunities to use those dollars elsewhere as a healthcare system, and the potential burden on caregivers. Each of these must be thoughtfully taken into account when selecting not only the right device for the right patient, but when we think about more widespread implantation of circulatory support devices. Now let's move on to the potential complications of contemporary continuous flow ventricular assist systems. These are data, again from Intermax between 2008 and 2014, looking at the freedom from a major event. On the left, we have the freedom from the first occurrence of device-related infection, bleeding, device malfunction, stroke, or death. And no matter how sick the patient is when the pump goes in, there is about 3/4 of patients who have one of those events by a year, and about 80% by 2 years. Those patients in critical cardiogenic shock are the most likely to have an infection, bleeding episode, device malfunction, stroke, or have an early mortality after implant, but all the other levels are about the same. And when we look at time to first readmission after discharge from device implantation, there's no difference in implant profile. There's a small numeric difference that reaches statistical significance, but again, half of patients have been hospitalized no matter the implant profile by 6 months, and 3/4 by a year. By 3 years after implant, nearly all patients have been rehospitalized at some point with a device-related complication. The common complications after a durable left ventricular assist device include driveline infection at 8 to 10% per year, stroke, either hemorrhagic or ischemic stroke, at just under 10% per year, aortic valve regurgitation, pump thrombosis at 6 to 10% per year, gastrointestinal bleeding, which is more common and can lead to transfusion, which can sensitize our transplant waitlist patients, as well as right heart failure, which can occur both early and late after device implantation. If we look at the potential cause of death from each of these device complications, by 6 years, and really after the first year of the device-related complications, the number one cause of death is from stroke, from neurologic events, followed by multi-organ system dysfunction, infection, and then device malfunction is a less common cause of death, but a considerable cause of comorbidity given the need for reoperation for device replacement. And then patients who develop right heart failure can have the same syndrome of fatigue, breathlessness, and congestion that they were trying to cure with the device in the first place. Let's turn our attention to stroke. Stroke is the most devastating complication of continuous flow LVAD technology. These pumps have a constant interface with the blood and so activate both humoral and cellular clotting cascades. All patients require obligate anticoagulation, and there is risk both of ischemic and hemorrhagic stroke with mechanical support. Data from Intermax on the right look at the survival after the first stroke on a circulatory support pump. The curve in blue is survival after an ischemic stroke, and in red, the dismal survival after a hemorrhagic stroke while on an LVAD. Over half of patients die within 3 months of having a hemorrhagic stroke with an LVAD. And survival by 3 years after any neurologic event is fairly poor. Patient factors, pump design, and clinical management factors all contribute to the stroke risk. And our current algorithms for reducing the risk of stroke include targeting an INR between 2 to 3 to prevent thrombosis within the pump, as well as aspirin to prevent platelet activation at the pump interface. Data suggests that novel or direct oral anticoagulants should not be used in this setting, and there is no data to suggest that they reduce stroke risk. In addition, blood pressure should be kept to less than 90 millimeters of mercury as a mean in all centrifugal flow pumps to reduce the risk of stroke. Pump thrombosis is a particularly concerning complication for the earlier generation pumps, the HeartMate 2 and the HVAD. Fortunately, the magnetically levitated HeartMate 3 has an improved profile of hemocompatibility, and so only a negligible incidence of pump thrombosis. With the earlier generation HeartMate 2 and HeartWare HVAD, the incidence is between 6 and 10% per year, depending on the case series. This is an example of what a pump thrombosis looks like in the upper right. There is a clot that has developed on the inflow stator and the rotor that increases the drag as blood moves through the pump. In addition, there's a ruby bearing in here that develops heat as the pump rotor moves. And if clot is on there, that heat is not able to dissipate as cooler blood washes by. And so there is thermal injury to the blood elements in addition to increased shearing. That leads to hemolysis, and a typical pattern of intravascular hemolysis with jaundice, pigment nephropathy, hemoglobinuria. The pump tells you that there's increased power consumption because it takes more power to move the blood with a rotor that's clotted. And there can even be catastrophic pump failure where the pump stops abruptly. The clinical diagnosis is made by an increase in lactate dehydrogenase levels in the serum or increased plasma-free hemoglobin, as well as inadequate left heart decompression during a ramp study through higher pump speeds. The treatment is typically getting the pump out, and that can be either with a pump exchange or a heart transplantation. Intravenous anticoagulation can be used to temporize or prevent early-stage pump thrombosis from advancing. But survival after each subsequent operation for pump thrombosis is diminished. So patients who require frequent pump exchanges for thrombosis do not do well. In addition to clotting, bleeding is a problem, as I've already alluded to. This appears to be a unique problem with the non-pulsatile continuous flow pumps and was almost non-existent with pulsatile VADs. And interestingly, the gastrointestinal bleeding risk goes away completely after transplantation. The incidence is between 10 and 20% per year, and it's thought to be because of the obligate anticoagulation or arteriovenous malformations or an acquired type 2A von Willebrand syndrome that happens because of the high shear stress breaking up the von Willebrand's multimers, very similar to Heidi's syndrome in severe aortic stenosis. The treatment can be blood transfusion, which can lead to sensitization risk in the transplant-listed patients, reduction in anticoagulation goals, which in turn can increase the risk of pump thrombosis, or the use of splanchnic vasoconstrictors like octreotide or anti-angiogenic factors like thalidomide, which can reduce the prevalence of arteriovenous malformations. Aortic regurgitation is also a problem that seems to be unique with continuous flow LVADs. Because of the continuous unloading of the left heart, the heart does not generate enough pressure to open the aortic valve with every beat. And if the aortic valve remains closed, the leaflets of the valve can fuse, retract, and lead to central aortic regurgitation from the aortic root, which is pressurized by the LVAD, back into the left heart, which leads to ineffective cardiac output as the blood goes in a futile cycle back to the left heart into the inflow cannula. The risk is about 5 to 10% per year and may escalate over time. And really the only solution to this problem is closing the aortic valve, either with a patch closure or sometimes a bioprosthesis. Driveline infection has commonly been described as the Achilles heel of durable circulatory support. Unlike a pacemaker or defibrillator, the power supply of the VAD is external because of the need to have a high instantaneous power. Therefore, there's a driveline with both telemetry information, the controller information, and the power supply that transits the skin, which is the natural barrier for infection. The driveline exit site can become red or have purulent discharge. That infection that begins typically with gram-positive organisms can track along the driveline and go back to the pump. Fever and sepsis can occur, but endovascular infection with endocarditis is actually quite rare. Unfortunately, the treatment, the way to get source control, is to remove all the hardware. These patients are seldom well enough from a circulatory perspective to be able to do that. And so transplantation is often needed. And as such, driveline infections are often thought to be treatable, but rarely curable if the device has to be maintained. Transcutaneous energy transfer systems are in active development that would allow energy to go from an external source to an internal generator and thereby prevent driveline infections by eliminating the driveline altogether. So with the revolution in durable mechanical circulatory support has come a parallel advance in temporary circulatory support. Now, temporary mechanical circulatory support has been in widespread use for really over 30 years, with indications that include a failure to wean from cardiopulmonary bypass at the time of cardiac surgery, or to bridge from a cardiac surgical intervention, or percutaneous intervention to definitive therapy. It's been used for temporary support after cardiogenic shock from myocardial infarction, while the stunned myocardium heals and is reperfused. And it can also be used as a temporary bridge either to recovery in acute cardiogenic shock, like myocarditis, or as a bridge to a durable device, like the LVADs we were speaking of before. There are four primary percutaneous platforms for temporary circulatory support, beginning with the classic intra-aortic balloon counterpulsation pump, to transeptal centrifugal flow assist devices like the tandem heart, or the transaortic axial flow assist device, the Impella device, and even extracorporeal membrane oxygenation, which is nothing more than a circulatory pump connected to an oxygenator. Let's begin with the intra-aortic balloon pump, perhaps the one we're most familiar with. The balloon pump works by augmenting diastolic blood flow and with a presystolic reduction in afterload. This arterial tracing of the aorta, when the pump does not assist, you have systole and diastole, and after the aortic valve closes, there's augmentation of pressure as the balloon inflates within the aorta. And then as the balloon rapidly deflates, just as the aortic valve is about to open, there's afterload reduction, which allows greater output from the failing ventricle. This allows for increased coronary perfusion and oxygen supply during diastolic augmentation, as well as afterload reduction and reduced oxygen demand during systole. Now, the intra-aortic balloon pump is very fast and easy to insert. It's widely available in all cardiac catheterization laboratories, and all operators are familiar with its use. It's contraindicated when there's severe peripheral arterial disease, and so you can't get the large caliber pump into the femoral system. It's also contraindicated when there's aortic pathology or regurgitation of the aortic valve, because that diastolic augmentation will actually further load the heart. The disadvantages to the balloon pump are the relatively poor augmentation of cardiac output, only about 1 liter or 1.5 liters per minute. And then the complications that include limb ischemia, hematoma at the access site, thrombocytopenia because of platelet consumption at the balloon, and even rupture of the balloon. Even so, there was a lot of enthusiasm about the use of a balloon pump in acute myocardial infarction complicated by shock. That enthusiasm was dampened somewhat by the IABP Shock 2 trial, published in 2012, that randomized 600 patients with cardiogenic shock from infarction with an early revascularization strategy in a 1-to-1 fashion to either balloon pump or optimal medical therapy. And there was no difference in 30-day mortality between those two strategies. And so even as enthusiasm for the use of balloon pump in shock has waned, there's been expanding interest in the use of different devices to support the circulation. This is an example of the transeptal percutaneous temporary VAD, the tandem heart, which is a centrifugal flow pump that gives non-pulsatile flow by removing blood from the left atrium and pressurizing the aorta by the femoral system. Anticoagulation is required for these continuous flow pumps because of the long tubing and the potential for clots. And it can even be configured for more durable surgical implantation. Smaller studies have showed that these bulkier pumps improve metabolic parameters and cardiac output relative to a balloon pump, but there are very real complications, including infection, arrhythmia, hemolysis because of the blood path, platelet consumption, and then vascular injury and bleeding from these very large bore catheters that can potentially lead to limb ischemia as well. Retrograde percutaneous transaortic pumps have been developed. These are axial flow pumps like a miniaturized HeartMate 2, where blood is sucked in to the inflow portion of the cannula via a small rotor and then out the aorta into the ascending aorta. This unloads the left heart and pressurizes the aorta and also improves coronary flow. This again gives non-pulsatile flow between 2.5 and 5 liters per minute. It requires anticoagulation because there's a catheter in the systemic circulation. It again improves metabolic and hemodynamic parameters relative to the balloon pump, but has the same potential complications as the tandem heart, including infection, arrhythmia because of a catheter in the left heart, hemolysis as blood is rapidly accelerated through that small bore catheter, thrombocytopenia, and vascular injury. The last support configuration is known as extracorporeal membrane oxygenation, or ECMO. ECMO can be used in a veno-arterial configuration where blood is taken out of the systemic venous system and pressurized into the systemic arterial system to effectively bypass both the heart and the lungs, and that can be used for cardiogenic shock. In respiratory failure, where oxygenation is the primary issue, veno-venous ECMO can be used. Typical support configurations can include central cannulation, where blood is removed from the right atrium, accelerated in a pump, put through an oxygenator, and then put back into the aorta. There can be peripheral cannulation, which is great for rapid implantation with femoral arterial and venous access. There can even be central cannulation, where the jugular vein and axillary artery are cannulated for ECMO, which can even allow ambulation for select patients suffering from cardiogenic shock. Veno-arterial ECMO is great for temporary biventricular support, and complication rates are dramatically less now than they were in decades past because of advances in the pump as well as the oxygenators. And ECMO has the singular advantage of being able to be used in multiple configurations for multiple indications of cardio or respiratory failure, and so a single platform can meet the need of many different patients. This table compares the different temporary assist devices that we've reviewed. Again, the balloon pump is pneumatic, relatively small in caliber, but gives very little hemodynamic support, but with a relatively safe profile of implant. ECMO, tandem heart, transeptal continuous flow, and the retrograde axial flow Impellas are much larger in caliber, and so access can be more complicated, and the risk of vascular injury and hemorrhage is more real. But as we pay that price, we gain a dramatic improvement in the potential cardiac output. And there is a risk of hemolysis and arrhythmia with many of these devices. Many centers are moving towards Impella because of the ease of implantation in a retrograde transaortic approach, or ECMO because of the ease and rapidity of femoral cannulation for temporary life support. So as we wrap up this review of mechanical circulatory support, these are the take-home points I'd like to leave you with. Contemporary continuous flow LVADs are a revolutionary treatment for highly select patients with advanced heart failure, patients sick enough to justify the implantation expense and risk, and those who will take good care of the pump once it's implanted. Durable support devices can now be used both as a bridge to cardiac transplantation, as well as for lifelong destination therapy, which uncouples advanced surgical heart failure therapies from the need to be on the transplant wait list. The Intermax patient profiles of advanced heart failure are a powerful shorthand for describing mechanical support candidates, with most implants being in profiles 1 through 3, those patients with critical shock or requiring inotropes. We reviewed how important the assessment of right heart function is for the decisions to proceed with LVAD therapy. If the right heart is failing, the LVAD will suboptimally function and patients can be left with debilitating heart failure even after a surgical approach. So adjudication and confirmation of the right heart is critical in selecting good LVAD candidates. Regrettably, complications were made common with mechanical circulatory support, but engineering advances such as the magnetically levitated HeartMate 3 have suggested improved hemocompatibility. Even so, these complications can deleteriously affect both survival and quality of life. We would anticipate in the years to come continuing engineering advances such as transcutaneous energy transfer, further pump miniaturization, and pump sensors to improve outcomes in our patients. But it is clear that improving pump design has led directly to better outcomes, as well as an evolving cohort of patients being considered for durable mechanical support. With that, let's move on to several questions to test your knowledge about mechanical circulatory support. Let's begin with a case. This is a case of a 72-year-old man with a remote anterior myocardial infarction who had a bypass operation, but suffers from an ischemic cardiomyopathy with reduced ejection fraction. He's intermittently breathless at rest and has had 3 hospitalizations for heart failure in the last 6 months. He has no significant ischemia or viability on a cardiac PET. Relevant comorbid conditions include diabetes with peripheral neuropathy, stage 2 chronic kidney disease, and prostate cancer, status post-radical prostatectomy. On echo, his left heart is extremely large at 7 centimeters at end diastole with functional mitral regurgitation, but a right heart that's only mildly enlarged with good right heart function is measured by the tricuspid annular plane systolic excursion. The ECG has a narrow QRS, and the peak VO2 is severely reduced. Right heart catheterization shows dramatically elevated left compared to right heart filling pressures and a reduced cardiac index at rest. For this patient, what is the most appropriate surgical heart failure therapy? Is it mitral valve repair, biventricular assist device as a bridge to transplantation, a left ventricular assist device as destination therapy, a reoperation CABG with a door LV reconstruction procedure, a heart transplantation, or a total artificial heart as destination therapy? The most appropriate surgical heart failure therapy for this patient is a left ventricular assist device as destination therapy after vetting the patient's psychosocial support and relative comorbid conditions and making sure that there's informed consent about potential device-related complications. This patient has advanced heart failure with a high risk of 1-year mortality given the recurrent hospitalizations and reduced peak VO2. The option to do a mitral valve repair for his secondary mitral regurgitation with this degree of ventricular dysfunction and remodeling can lead to further hemodynamic compromise. This patient is advanced in age at 72 with a recent malignancy rendering him ineligible for transplantation, so all the bridge to transplant options, biventricular assist device or total artificial heart, cannot be deployed. In addition, those devices are not approved for lifelong therapy. Left ventricular assist device as destination therapy is the most appropriate surgical treatment given his excellent right heart function by both hemodynamic and echocardiographic assessment. Moving on to question 2. Which of the following statements is false about the intermax profiles of advanced heart failure? Profile 3 patients are inotrope dependent. Lower intermax profile is associated with greater length of stay and mortality after VAD surgery. Most LVADs are placed in patients in profiles 1 through 3. Intermax profile 7 patients are in New York Heart Class 2. And profile 1 reflects critical cardiogenic shock. Which statement is false? Well, the false statement is that intermax profile 7 patients are not in New York Heart Class 2, but rather are in advanced New York Heart Class 3. All of the other statements about the intermax patient profiles are correct. The last question is as follows. Each of the following is a common long-term complication of continuous flow LVAD therapy except percutaneous driveline infection, gastrointestinal bleeding, pump thrombosis, stroke, or pump rotor cavitation. The only one that's not a long-term complication here is pump rotor cavitation. Driveline infection, GI bleeding, pump thrombosis, and stroke are relatively common long-term complications. Cavitation is the formation of bubbles in a liquid, particularly when a propeller moves through it. Fortunately, with current pump designs, pump rotor cavitation is not a common long-term complication. All the other answers, however, are. I'd like to thank you for your attention on this overview of mechanical circulatory support. Here are some additional supplemental references for further reading about this topic.